everybody. For the next talk, then I would like to invite Dr. Dhanashree Ratra. I think after discussing the two ways of dissection, I think the next thing would be the tackling the very morbid combined retinal detachments. I think ma'am is a senior faculty at and teachers of teachers from Shankar Netralaya, and I think it would be extremely nice to listen to what she has to say. Thank you.
Thank you very much, Gagan, for the kind invitation and also for this kind introduction. So I will be talking to you about tackling combined retinal detachment, and after all these excellent surgeries that you have seen, I think there is very little remaining, but let me cover whatever is there. So the combined retinal detachment by far I think is the most challenging case that a VR surgeon will encounter in his lifetime. So the complexity of the surgery is increased by several folds. That is because this retina is very thin. Retina is very thin, mobile and ischemic, and there is no counter traction for your membrane peeling. So whether you are doing unimanual or bimanual, so the counter traction is not there. So since the retina is also very mobile, and the moment you try to peel the membrane, the retina also gets lifted. So you can see how difficult it is here for me to peel this small fragment of this membrane because the retina is so mobile. Also, the identification and the separation of the posterior hyaloid might be very difficult. Often you will see that the retina is so thin and the membrane is so thick, so it's like totally opposite. And it's also very fragile, and the moment you touch the retina, it gets has a iatrogenic break. So it's very important to have a very proper preoperative assessment and planning for the surgery. Make sure that you have the required instruments ready, or use the best quality instruments which are working properly and which are probably new. And also you have a good visualization system, because all this matters a lot. Otherwise it becomes very frustrating to work with instruments which are not working, or if the visualization is not good, that adds to your complexity. So make sure everything is in proper order. Preoperative anti-VEGF, I will not go into the details, but definitely it has a role to play, because especially in situations such as this where the extensive membranes, anti-VEGF works like a wonder. The only caution is that already the retina is detached, and hence there is a higher chance of contraction occurring, and further retinal detachment can get worsened. So here the caution is that you operate earlier. After injecting anti-VEGF, don't wait for too long. Maybe within 2 to 3 days you should operate on such eyes. This is an eye you can see where I think anti-VEGF has been given, and it is a large membrane at the disc. So this the first initial step is of course to do the truncation of the vitreous and remove the peripheral vitreous. And here I am using the scissors. So I actually like scissors for dissection. The advantage is that the scissors have a precise cutting, and the bleeding is less as compared to the cutter. But of course even the cutter is also good. So if you whichever is comfortable and whichever you feel happy with, you can use. So after you go into the correct plane of dissection, that is under the second membrane, then you can fold back the membrane and cut these adhesions, the nails which are there. So this I am doing unimanual, but you can also have a bimanual approach in this. So if you are in the correct plane of dissection, then the dissection is easy, and then even if it is unimanual, you can still do the dissection well. So you can see here the retina is not that much disturbed, and it is easy to do the dissection. So maybe we'll go to the next case. So this is a bimanual surgery. So especially in combined retinal detachment, I think bimanual would be better, because with bimanual surgery you have more control over the membrane, and also the retina is not disturbed much, and you can actually cut these nails quite easily without the retina getting pulled too much. So I think for combined retinal detachment you should plan for a bimanual dissection. So here there is a large membrane which is getting cut. So I definitely use this bimanual technique, and sometimes you can even if this is a very large membrane, here we are using only one chandelier, but sometimes you can use 2 chandeliers also to illuminate the entire retina well and do the bimanual. So this is another situation where this is a combined retinal detachment. Here actually the whole retina, it's like a closed funnel at the disc. So the Sangeet's technique might not work here because the retina is also like inside. It's like one bunch which has gone inside the disc. So here the advantage is that you should do from center to periphery dissection, especially in combined retinal detachment. That works because after you have removed this vitrectomy, I have another video actually which shows you the combined retinal, the center to periphery dissection. So here maybe I'll just fast forward this. So you remove this, remove the peripheral vitreous, and then I have switched to bimanual technique here. So you can see this is the stalk which was there inside, and there was another membrane which you see inferiorly. Even this membrane was also actually inside the retina, like one bunch it had gone inside. So it becomes a little bit difficult, and you can see the pre-existing breaks are there here. So it becomes a little bit difficult. It is also important that you don't enlarge the pre-existing breaks, because the breaks get enlarged in the beginning of the surgery itself. Then the surgery becomes that much more difficult because the retina becomes mobile. So also do not remove this SRF prematurely, because this SRF which is there is actually thick and viscous, and it's actually giving support to your retina and does not allow the retina to get lifted when you are doing the dissection. But if you remove the SRF, if you drain the SRF prematurely, then the retina becomes even more mobile, because the fluid, the infusion fluid which seeps inside makes the retina more mobile, and then that creates more difficulty in your surgery. So this is the end of this thing, and this retina, you can either put gas or oil, but more often than not we are putting oil because of the multiple breaks and large amount of TRD or CRD which is there. Sorry. So this is another situation where there is a membrane and the hyaloid face which is plastered to the retina. So in this situation, I also start from center to periphery, but instead of pulling the membrane, I use either MVR blade to create a nick in the membrane, and then you can use the scissors to create the plane there. And then afterwards you can either do unimanual or bimanual, but this vitreous which is adherent to the retina all around needs to be removed. So I guess each technique has its advantage and disadvantage. So whatever you think is good for you, you can do. So center to periphery can work quite well for combined retinal detachment. So this is the cutter which I am using for combined retinal detachment. I generally use a 23 gauge system. Sangeet has shown with 27 gauge system. So you can see even with a combined retinal detachment, the retina is quite stable and it does not jump as much as you would expect it to be. However, you still have to be very cautious because the retina is thin, mobile, and you can end up with multiple iatrogenic breaks. So you need to be very, very cautious. Most important is that you have to dissect the entire fibrovascular proliferation from the membranes, from the breaks. And if you have created iatrogenic breaks, then it is more important to clear all the breaks of the fibrovascular membrane, because any residual fibrovascular membrane is going to contract and will lead to recurrence. Role of scleral buckle, there is actually not much role because most of the breaks are actually posterior and you cannot buckle them. And it also will increase your surgical time and higher chances of corneal edema. There is also a higher risk of anterior segment ischemia because it's already in a combined retinal detachment is already in a very global ischemic state, so you have to take into account that. However, if there are any peripheral breaks or there are breaks where you have not been able to remove the vitreous or the fibrovascular proliferation, and if they can be buckled, then maybe you can try and buckle these situations in this situation just to prevent any recurrence. But I have almost never done any buckle in a combined retinal detachment. But just for the sake of discussion and for completion of this, I have added this point here. So to conclude, that diabetic combined retinal detachment remains the most challenging surgery that a VR surgeon will encounter. Retina is very thin, ischemic and fragile, and the risk of iatrogenic breaks are very high. Combination of techniques and combination of instruments such as multifunction instruments also can be used. Removal of the fibrovascular tissue from near the breaks is very important. And despite good anatomical results, sometimes the visual outcomes are quite poor. So you need to counsel the patient accordingly. Thank you very much.
Thank Thank you, ma'am, for this.
Cataract is not much. You are still able to visualize the retina. You think you will be able to do the surgery. Then in these situations, I do not do a combined surgery. I mean, I do not do a phaco because a combined surgery always creates more inflammation and higher chances of all problems. Like I said, even NVG and all can develop. So in this situation, I first do the retina surgery, settle the retina, and at the time of the silicone oil removal, then I'll plan for the phacoemulsification. But if the posterior disease is less, that means the fibrovascular proliferation is small, the amount of RD is small, then I do a combined surgery.
So for combined retinal detachment, one thing Dr. Dhanashree has highlighted is to remove the membranes to the maximum. If there is a break, you can't leave the membranes. In normal TRDs, you may still leave some areas of traction on the nasal side, which is not affecting the macula, but for combined, it is not. You have to remove all the traction which is there. Second is like in combined retinal detachments, as she mentioned, the subretinal fluid is very thick. And so you do a fluid-fluid exchange before you start attempting the fluid-air exchange to completely flatten the retina. I think this is another point I'd like to make.
And anybody using scleral buckles actually, or a belt buckle for that matter, just to support it?
No, I don't. Because initially I used to do when I just completed my fellowship, because of fear of all these redetachments, but I realized that the chances of anterior segment ischemia, they increase very, very high. They become very, very high, and patient will come to you with recurrent vitreous cavity hemorrhages or neovascular glaucoma.
So secondly, the choice of tamponade, I think usually what we follow is that if we have a combined detachment, though we are also shifting from that, but if you have a combined detachment, especially chronic TRDs and with a combined detachment, or a chronic TRD converting into a combined detachment, so oil usually was the earlier school of thought, but then as of now, I think what I hear and what I also see is that oil per se action on the disc is way catastrophic than probably using gas. So what's your take on that? I think.
So for superior brakes or peripheral brakes, gas is quite okay. You can put gas, but sometimes if you have multiple brakes or if you have inferior brakes, then I don't think the gas will be that good. So oil would be a better choice. Yeah.
So for me, if I'm able to settle the retina and laser the brakes, I will prefer to do gas only, and I have removed all traction. That is the minimum thing. You have removed all the traction. I'm able to settle the retina, laser the brakes. I'll just do gas. If there are large brakes like other indications of oil, I'll definitely go with oil at that time. Just remember one thing is like if you have an open brake, there is fluid still between the retina, still under the retina. Then you can't leave it with gas only, because this fluid takes sometimes like months together to go. And once the gas has gone and you are still have an open brake, it is again a disaster. You are going to land up in a recurrent retinal detachment condition.
And also, not for a combined detachment, but sometimes you have these very high TRDs, and if you're able to kind of manage the membrane, and you're very sure that you've not caused any iatrogenic break and there is no break. So what is your, your threshold of using a tamponade, even if you're a little scared or something, or you're able to leave a very high TRD and let it settle on its own? So what's the take on that?
So if just there is a TRD and there is no iatrogenic break, if you are sure there is no iatrogenic break at all, then actually I don't do any tamponade. Sometimes I may leave air, that is for hemostasis, but I don't do any iatrogenic retinotomy to drain the fluid. I just leave that TRD as such because I believe that it is better not to create an unnecessary break. And over that period, over the time, the retina will settle. It may take long time. Sometimes if there is a very chronic detachment, then it may take some time. But I still feel that it is better to leave it that way rather than to create a retinotomy and then give a tamponade.
So I generally, in these kind of situations where there's a high TRD and there's no break, what I generally do is, although it's a controversial thing, I generally put SF6 in those lesions and ask the patient to lie prone. So what happens is that mechanical displacement of the fluid goes to the sides, your retina gets settled quickly, as we do in the submacular hemorrhage cases.
But you don't do any retinotomy?
No retinotomy.
Just a tamponade. Yes. That I also do, but I give only air.
Yeah, that's true.
That is what my question actually was, because I used to do that, and then there was one case which we had done a few days back, and with a very bad outcome, and the other I done elsewhere, and we left a very high TRD, And I was, for 3 weeks, I was just going on thinking whether this is really going to settle. And
It
in
takes
3
months
weeks,
to
it
get
really settled very well.
Yeah.
So I think that is one thing, that if you don't have a nitrogenic brake, maybe leaving a high TRD with some fluid is not something to be scared of. So that was that. So any additions from Dr. Ritesh and Dr. Darius?
I want to ask, I think already Dr. Sangeet has partly answered the question, but what is the endpoint of your route? Like I agree, in CRD you have to remove all membrane. But for other cases where you have proliferation and membrane, do you leave the nasal areas or you go after every shred of membrane? What is your endpoint of your vitrectomy?
I try to remove everything, but sometimes if it is in the cost of causing breaks and putting in oil, then I'll definitely leave it.
See, you can leave islands of tissue which are like very adherent, which you are not able to remove. You can leave some few islands, that does not matter. But you should not have any tissue which is bridging 2 points. Any tissue bridging across 2 points will contract. So even if you have left a very large island which is across 2 points or across superior inferior or across right left, that will contract. So that you should not leave. And any peripheral sometimes you can leave the peripheral vitreous skirt. It might not be very easy to remove. But again, if the peripheral vitreous skirt has a band of vitreous which is coming posteriorly, that is again going to contract. So don't leave any connection between anterior and posterior. You should cut off any connection. So fibrovascular polyps also, you cut off the connection anteriorly. You may leave posteriorly some amount of tissue if it is not possible to remove. But if there is an hydrogenic break, then you have to remove it. If it is not possible to remove, then you can just do a retinotomy and cut off that entire tissue.